welcome everyone and say thank you for joining us today. Um, my name is Tasha Poinsett. I'm the Colorado Director with the Healing Advocacy Fund, and I think many of you may already be familiar with us since we have shared this out with our newsletter list and whatnot. But for those who may be unfamiliar, the Healing Advocacy Fund is a 501c3 nonprofit. And really, our goal as an organization is to support the state regulated psilocybin therapy programs to be successful. So we've been working in Oregon for a couple years now. Probably coming up on 4 years in Oregon, and then 2 years in Colorado. And then just recently, we hired our first staff person in New Mexico who's excited to be helping out there. And really, the model is just how can we work and collaborate across these states to support these models to be responsibly implemented to support client safety and affordable access. And today we are excited to be joined by Adi Ray Wilson Poe and Jazz Kadash from Open. And to give a little bit of context about why we wanted to host this call, I think I came across Adi Ray and the work at Open probably about 2 years ago and was just really blown away by how carefully they're thinking about this question of how do we really measure and track the impact of these state-regulated programs, both in terms of safety and adverse events, but also understanding how and if people are benefiting. And I think out of everyone I've encountered in the field, they've just really spent a very immense amount of time digging into the very hard questions around how do you try to track this outside of a clinical research setting and in the real world, where there's just such a greater degree of complexity and variables to navigate. And so I think we have so much to learn from this team at Open, from the work that they're doing. And I will also say that in Colorado, we were really privileged to be able to hear from them, I think, early on during the advisory board process, as our natural medicine advisory board was considering recommendations around rules for the state program. Adi Ray came and did an amazing presentation for the board that I think helped them understand this complexity as well. And of course, now that we do have a live program here in Colorado and a legislative change that happened earlier this year that gives the Colorado Department of Public Health and Environment the authority to do some rulemaking around tracking impact and outcomes in the regulated program. I think that there's even more reason to be really tuning into the work that they've already done and trying to understand kind of what are the opportunities here. And they also have a live platform that they will share a lot more information about that people can start to be facilitators and clients can start to participate in the immediate future in starting to understand these different variables and how they connect. So with that, I'm going to go ahead and hand it over to Jazz and Adi Ray to introduce themselves.
Adi, would you like to go ahead and then I can pick it up and yeah.
Sure. Yeah. So my name is Adi. I use she, her, dude pronouns. I am the co-director of the Open Psychedelic Evaluation Nexus, which is based at Oregon Health and Science University here in Portland, Oregon. My wonderful team and I have been working on this initiative for about the last 3 years. Jazz is going to go into a whole heck of a lot of detail about who we are and why we're here. And how best to support you. And really, Jazz is going to do the heavy lifting today. I'm really just here to support. So I'm seeing some familiar names in the attendee list. So thank you so much for tuning in and being here with us today. We're really looking forward to sharing our work with you and answering any questions that you might have about the research. Go ahead, Jazz.
Oh, I guess, sorry, a quick housekeeping note before I hand it to you, Jazz. I just want to note that we do have the Q&A open. So if you have questions that come up while they're going through the presentation, feel free to throw them in there. And then we will have a healthy amount of time at the end of the session to dive into Q&A. So yes, please keep the questions coming and I'll hand it to you, Jazz.
Yeah, thank you. And yes, definitely a healthy amount of time. I like that choice of words. We get so much from the Q&A kind of portion. So we're really looking forward to hearing from you all. But yeah, thank you. Thank you so much for having us, Tasha. It's really an honor to be here. And as we already mentioned, our last presentation with Healing Advocacy Fund has just been such a source of support for us, and we're really excited to do this again. Really focused on the Colorado facilitators. So yeah, thanks for having us. And I'll just get into it. But first, I'll just give a little introduction. My name is Jazz. Maybe some of you know me from various spaces. I am a cultural and medical anthropologist, and I actually served on the steering committee for the Natural Medicine Health Act of Colorado, along with Tasha and others who are involved with Healing Advocacy Fund. And so it's really nice to be back involved with Colorado, psilocybin facilitators, just on the other end of that. And so today I'm coming to you to speak about this new project that I'm honored to be working on, which is Open, which is the Open Psychedelic Evaluation Nexus. And I will just start sharing my screen here so that you can start following along with me. And I know you can probably see the top bar, but is this kind of big enough for everyone? Can everyone see? Okay, cool. Okay. Great. So Open is a practice-based research network, which is also otherwise known as a community-wide research collaborative. And what that means is that we're kind of all in this together. Everybody who's part of the research study is really contributing to the existence of the project. And the research is being conducted, as Adi mentioned, at the university level with Oregon Health and Science University. But the facilitators and the clients are really equal partners in bringing this research to life. And so that's what makes this a community-wide research collaborative. And something that I really enjoy about this study is that it gives the opportunity for us to start getting folks involved in research that they typically don't get access to. And so I'll share a little bit more about this later, but that community element is something really important to me and really something that makes this research really unique. And so the goal of the research with Open is to assess the effects of state-regulated psilocybin services, and primarily to assess safety, success, and equity in these environments. And so what we have determined in the past, before we've had these community models, right, is that in Indigenous settings and traditions, we see a lot of safety and sorry, we see a lot of value, right? We've seen in Indigenous communities, there's been a tremendous amount of value in how psilocybin is used. And in clinical trials, we've seen a lot of safety and efficacy in those environments. But what we have yet to determine is how those findings really translate to the broader community-based settings that we're not now starting to see in Oregon and Colorado. And so as these new environments have started to develop, we've begun to ask ourselves, are community settings just as safe as clinical trials? And how are services actually being delivered in these newer environments? And are they accessible, right? Are they equitable for folks, anybody who wants to kind of access them? And so these are the questions that we're really looking to study at Open. We see psychedelic data as a shared natural resource, which is something that is meant to ultimately serve public well-being and also be a source of collective wisdom. And so with that, that involves responsible care. And so we really see, instead of a steward, a collective, sorry, instead of a data kind of ownership model, we're really taking our job as data stewards. And it is our job to safeguard this data so that it can both serve today's needs, but also the future as well. And so to ensure this, we've built a very strong ethical and legal safeguards. We have received IRB approval, which means that our research meets US standards of ethics. And we've also gone a step further to receive a federal certificate of confidentiality, which ultimately protects facilitator and client data from any legal subpoenas. And what's really great about this is that this is actually a step further than and a stronger protection than HIPAA would provide. And so HIPAA is the US law that protects privacy um, and security of any medical information, which community services and regulated models like in Colorado don't really qualify as medical data at the current time. And so HIPAA wouldn't really comply to community-based services. And we've even gone a step further and received that federal certificate of confidentiality, which means it really is at the highest standards of ethical protection. And I will also just take a moment to just note that achieving this level of protection in a new field like psychedelics is truly a rare and hard-won accomplishment that the team at Open just spent so much time working on, and yeah, just a moment to honor that work, because it's truly the highest standards of confidentiality. So once we have received those kind of protections in place, the next big question is, what do we actually want to measure here, right? How do we actually define safety and success in psychedelic services, especially when we're really working outside of this diagnosis-driven medical setting, right? Now that we're in Colorado, and as well as in Oregon, we're not so much focused on treating uh, particular diagnoses, but we're also just providing services to people with um, any kind of lived experiences. And so, how do we really determine what safety and outcomes look like once we start exiting that diagnosis medical setting? And what we notice is that there's very little academic literature focusing on these questions specifically. So we had to build that framework ourselves. And our solution to building that framework was to create a secure research platform where facilitators and clients can both participate as research contributors. We also realized that as we were creating this, that the way that we actually define safety and outcomes is literally through the questions that we ask participants. And so, in order to understand these, we very carefully and empirically chose these questions with expert consensus, because we also know that as we kind of ask these questions, we're also determining how safety is going to be defined for the entire field moving forward. Right. And so this platform is not just a data collection tool, but it's also a vehicle for shaping what safety and success and equity actually mean in community psychedelic services, because we're in such a new field. And so as we were figuring out how to define safety and outcomes, we went through a very rigorous process over the past 2.5 years, where our central focus has been to answer one big question, which is, what does safety look like? And what does success look like in state regulated psychedelic services? And so to do this, we built a process that, as I mentioned, was both very rigorous and very deeply community based. We drew on our council, which brought together and continues to bring together academic partners, including Denver Health and the Oregon Health Authority, as well as licensed and unlicensed facilitators. We had Indigenous wisdom keepers, regulators, health agencies, really just all types of community-based experts in the field. And what we quickly saw was that there were real gaps in what the field had already captured in academic literature, and really what these community leaders already knew. And so we sought to fill those gaps ourselves. And one of the most important steps in achieving that was conducting this Delphi study over here, which is a structured and multi-step process to identify which measures and questions mattered most to the facilitators and to the experts in the field. And so we engaged those 36 expert facilitators, and all of them had an average of 15 years of experience, and just asked them directly, what is the most essential information to capture if we truly want to understand what client safety and success look like. And so in this process, we determined, we came to the following questions. And so over here, you'll see a breakdown of the measures and questionnaires that clients might see, which was developed directly through our Delphi study, as well as ongoing research. And so across the top row, um, you can see the survey schedule. So the baseline survey is completed when a client first consents and enrolls into the study. And it's really important, actually, that this baseline has to occur before any administration session happens. And so ideally, this happens on a separate preparation day. It doesn't necessarily need to happen during a prep session that you have with a client. But it could happen in their homes because this is a web-based platform. The clients can do the baseline surveys in the comforts of their own home. But it is really important that they fill out the kind of baseline questionnaires before having any administration session. And you'll see here that actually the baseline questionnaires are actually the longest, and it takes about 20 minutes to fill out. And the reason for this is because it asks all the initial questions, right? And so you'll see here, for example, there's quite a bit on substance use, but if your client is not engaging in any substance use, not smoking tobacco, for instance, then it will engage in skip logic where the following questions won't be asked. And so it could be a lot shorter. And then after that, we have follow-up surveys, which are much shorter and sent at 1 week, 1, 3, 6, 9, and 12 months after the session. And so this schedule here allows us to track how experiences and outcomes really evolve over time, right? But again, we wouldn't be able to track that if we didn't have the administration session in between the baseline and the 1 week. And then on the left-hand column over here, you'll see all the domains that we measure. So again, these were carefully selected with input from the 36 experts that I was speaking to earlier. You'll see the items in red are priority questions around safety and mental health changes. And these represent our primary outcomes. But there are all of these other items that felt really important to our facilitators to ask about. And so we made sure that we we spent the time really understanding exactly what was important to our facilitators to measure. And because our platform is custom built, we can always adapt this and we can always refine the measures and based on what our community of facilitators are telling us, and including any facilitators like you all who might want to see different things. And so overall, we spent, like, for example, I'm just going to look at anxiety. There are many measures measuring, many questionnaires that measure anxiety. And we went through this very rigorous process that went through every single one of those um, uh, questionnaires and really went through each and every question to determine which one of those questions was most important to ask so that the client on the other end is not just filling out tons and tons of questions on anxiety, for example. And so that was part of our Delphi study to understand exactly which question was the most valuable to be asking the clients. But overall, the list may look long, but completing these surveys is a very straightforward and approachable process for participants. One thing that excites me most about this project is that it opens participation to people who are typically excluded from traditional research. Um, Clinical trials often screen out people with complex health conditions and comorbidities, and people who are taking multiple medications, for example. And as a result, historically, study samples have been dominated by mostly white, mostly male, and highly educated participants, which is ultimately just not reflective of real communities, and the people who are really engaging in these services. And so our approach here helps to capture a true breadth of lived experiences. And that's why it's so important to see how the clinical trial results that we've seen so much data on really do translate in whether they do translate in diverse and community-based settings. So I'll just go over a little bit of, I've been sharing just a lot of information. And so I'm just going to give you kind of an overview of exactly what it does look like to participate in the study, and what those steps include. And so firstly, we in our model, facilitators are research participants themselves. And again, I'll just reiterate that all the information is protected under the Federal Certificate of Confidentiality. And though that may be repetitive, we will talk about that much more, but I just can't stress that enough. It's such an important piece of the research study. And so the process begins with the facilitator consenting, and a one-time survey covering who they are and where they work and what their licensure status is. And understanding what the licensure status is really important because it allows for us to understand the differences between licensed and personal use models. And actually, our IRB approval allows data collection regardless of licensure and regardless of location or even the substance or environment. And so, whether or not you are licensed, you can participate in the research. And so once you do consent, a facilitator would receive $75 gift card for enrolling in the study. And this is a process of just reciprocity and honoring you for your time, for participating. And then facilitators invite their clients to participate. And again, this happens before any administration session. And then the client fills out the baseline survey, and then after the client kind of completes the baseline survey on their own device, and then there's the administration session, facilitators are then asked to clients fill out the surveys, and then facilitators are also asked to fill out a short kind of session details, takes less than 5 minutes, just to report on if there were any safety events or what the dosing was. And then facilitators receive a $50 gift card per session that they submit information on. And then client follow-up surveys are sent to the clients in a kind of automated kind of fashion, and this can happen via email or text, depending on what the client prefers. And every time the client fills out a survey, they receive a $50 gift card as well, totaling $350 across the entire study, with all of the post-session kind of follow-ups up until the 12 months. Then all of the data is stored behind a firewall protected repository at OHSU. And then we have a feedback loop where we aggregate analytics and we share that with facilitators as well as healing centers in order to help them improve on their services. And this is something actually that state level data collection just doesn't provide. So we can aggregate specific data to share that with the service centers that you're working with, as well as with you. Let's see. So yeah, I think that goes over the general kind of overview of exactly how it works within the study. Over here, I will just kind of go over some of our numbers on recruitment and retention. So far we have 64 facilitators enrolled in the study. And again, most of these are coming from Oregon. Um, and that includes facilitators that are working at 17 out of the 21 healing centers in Oregon. Um, Colorado is not quite there yet. Healing centers are not yet providing a lot of services to clients, and so yeah, most of this is in Oregon. But with the 64 facilitators, we've had those facilitators enroll 196 of their clients. And we're actually just seeing just such great numbers on retention in terms of, how much people are continuing to participate in the studies and in the follow-up, post administration session surveys. Um, so in the results that we've gathered thus far in Oregon, we've actually noticed that self-reported safety is very high. And the vast majority of participants report no harms and no unwanted effects, and no challenging experiences either. Um, we have also been comparing our data to the mandatory reports that have been submitted to the Oregon Health Authority. And we've actually seen a really strong alignment on this piece where very few safety events and minimal accounts of harm have been reported. So this is especially reassuring to us because our data set represents roughly 10% of the population that is reporting to the OHA. Yet we're still seeing the consistency, and that consistency really suggests that our data is representative of broader service outcomes. But what makes this exciting is that we're not just capturing administrative events, like what the facilitator administrated to the client, but we're also hearing directly from participants themselves about their lived experiences. And this gives us a richer and more nuanced picture of what safety looks like than what regulatory data alone can provide. And I'll actually give a really great example of this. So we had one case that was flagged as an adverse event. And this was because the client went to emergency services. And so on paper, at the state level, that's a very clear red flag, right? And one that would be counted as a negative outcome. But when we reviewed that same client's own survey responses in our data, they actually reported no unwanted effects or safety concerns. In fact, they said that the adverse event was actually helpful to their overall experience. So you'll see over here a quote from the client. They said, "I was really embarrassed about my behavior, but ultimately the session was incredibly useful and it's made a big positive impact on my life." And so this instance matters so much because the state level data really captured what happened, right? The client went to emergency services, but it didn't capture how it was experienced, right? And without the client's perspective on how they experienced that quote adverse event, the story is simply incomplete and also can even be misleading, right? And so our approach with this data and this research closes that gap by combining objective events, like what happened, with the subjective meaning that the client really received from that experience, so that we can not only just understand safety in that clinical sense, but also the personal utility and value of this experience itself from the client end. So let's just get into some more preliminary data, and then we'll get to some Q&A really soon. I know I'm giving you guys just so much information here, so thank you for bearing with me. Um, So the magnitude of reduced depression and anxiety symptoms that we're seeing in our current data set is actually not very surprising. It's very similar to what's been observed with antidepressants, medications, and as well as in psilocybin clinical trials. But what is remarkable is the consistency of these effects across participants, regardless of background and regardless of setting, right? This is happening in all kinds of different environments, contrary to clinical trials where it's the exact same environment, right? But where we actually see variability is very common. So some participants improve dramatically in clinical trials while others see very little change. And what we're noticing is that here in real world community settings, such as the Colorado and Oregon landscapes, we're actually seeing meaningful improvements across the board without strict controls of a lab environment, right? And that consistency suggests that these benefits are not just a product of ideal kind of clinical conditions or an environment that was created by a lab, but that they may actually be achievable at scale in everyday practice. And so that has been some really interesting kind of findings that we've gleaned so far from the data we've collected. The last thing I'll kind of go over here is um, just kind of sharing the differences um, between data, because not all data is the same. Sharing findings is very different than sharing insights, and it is really valuable to go over the differences here. So I'll just name, for an example here, we have 80, and client level data would include both non-identifiable details like the dose that she took in in a session, um, as well as personally identifiable information like their name, email, and phone number. So sharing this level of data would require IRB approval, as well as a formal data use agreement. And we normally only share this type of information with other research institutions. However, we currently do not have any agreements in place for this level of sharing. So we're not sharing any client level data. Then we move into aggregate data, which actually combines information from many clients in order to show an overall kind of trend. So this would include things like demographics and safety events and health outcomes. And even though it's de-identified, right, like it's not including the person's name or email or any personally identifying information, it still does require an IRB approval, as well as a data use agreement. And currently, we do have a bi-directional agreement with UC Denver, allowing us to exchange aggregate survey data. But that would be the only instance that we're sharing aggregate level data. And then we get to results, and results are really what we just saw in this previous slide, for example. And these are designed for public sharing. This is shared with health agencies and professional associations like Healing Advocacy Fund, for example, and insurance companies, as well as others. And uh, these are sharing these results with various kind of stakeholders in the movement really can really improve the vast knowledge that people have access to, right? And that's really part of our goals is really just sharing that information with people who could really benefit from it. And so results contain no personally identifiable information. It's really just numbers and patterns and key takeaways. And so just to reiterate, we never share individual client information outside of any approved research agreements. What we do share are publicly are de-identified results that are summarized and anonymized so that they can inform the field, but without compromising, client or facilitator privacy, right? So privacy is just at the utmost importance for us. And so, as we're closing, and please, start thinking about your questions, because we would love to hear from you. And I'm seeing a few popping in the Q&A. I just want to share about where we're headed next, and really why this is important to us. And so, our project is deeply committed to ultimately enabling healing centers and facilitators to truly improve the quality of the services that they offer, right? And so this means taking what we've learned and turning it into concrete tools and trainings and best practices that really can be applied right away in the real world setting and environments that we're currently in. We're also looking to share our findings with policymakers, because it's ultimately what will, like, this data and what we're learning from facilitators and clients is going to ensure that the decisions that are being made at the legislative level actually reflect what's working and what's not working on the ground, right? Um, and one area that we're especially excited about is also potentially informing or improving the informed consent process, right? When clients come into an experience, they want to understand exactly what they're potentially signing up for. And when they have access to this open database, and can actually understand what are other people experiencing, that can really impact the what informed consent actually means for the people that are looking to um, you know have these experiences. And so there's many things that we hope to do with this information, but ultimately what we're looking to do is create a future where safe and ethical and effective psychedelic care could be made available to those who can truly benefit from it, and where policy and facilitator practices and healing centers, as well as public perception, can really all work together to make that future possible. And we can only do that when we actually understand what is happening on the ground, and really learning from that, and improving our processes as we're in a completely, yeah, just new field. So yeah, I really look forward to just seeing what's happening on the ground in Colorado, um, since we're really just at the front lines of it. If you'd like to enroll in the study, you can email openstudy@ohsu.edu and just say simply, I would like to enroll in the open study. And then we'll send you the consent form and all of that. And so if you have any questions, we're here. We've got a whole 20 minutes for Q&A. And thank you for bearing with me. I know there's so much information here, and also working on consolidating the story. But yeah, it's such an honor to be part of this research and to be connecting with all of you. And thank you again, Tasha, for having us.
Yeah, absolutely. Thank you, Jazz, for that wonderful presentation. And I am happy to kind of go through and share out some of the questions. I know that Adi has been responding to some of them in the chat, which is great, but we are recording this and planning to share it out. So I do want to try to get some of those responded to verbally as well. Before I launch into that, though, I just wanted to say, cannot overstate the importance of this work. And I think when we think about where we're at in Colorado, in terms of like the community buy-in piece, and in particular, when I think about local governments and how they're still making decisions around how to respond to this program, how to regulate it at the local level, they are really hungry for information about safety, about outcomes. And I think we saw that, in Colorado Springs at the time when the city council there was making a decision about whether or not to sort of allow this within that city jurisdiction. And one of the things they said is like, we'd really love to see more data. At that time, we had really just sort of bare bones information. We were able to estimate 10,000 plus clients going through in Oregon and only 12, I believe, adverse events at the time, which is a really, really solid safety number. But it's very clear that this just tells the story in such a deeper way that really captures kind of the full scope of what these programs are all about. So just really appreciate your guys' work to bring that. And I think the policy implications, both in Colorado and then in future states as well, are really potentially profound. So I wanted to share that. And then in terms of the types of questions we're getting here, so we got a question in the context of the Colorado program. Are there any unique protocols for data collection through micro healing centers or cases of at-home use? Is any of the data collected conducive to estimating the effect of these different settings on treatment outcomes in the sense of the set and setting concept?
Yeah, do you want me to just re-answer live?
Sure, yeah. And yeah, I'll let you answer and then I might be able to add a little something too.
Yeah. So we do have survey questions that allow us to distinguish between different types of environments, licensed and unlicensed. Um, we might need some more due diligence around the difference between the micro healing centers and the other licensed healing centers. That's a very easy thing for us to implement, so long as we know exactly how to phrase those questions. As one of the benefits of having this fully custom platform is that on a moment's notice, we can make those kinds of adaptations. So yeah, so we do that currently, and we also have the opportunity to refine it.
That's great, Adi. And I wanted to share that because I think that's a really good question. We do have some differences in Colorado's program versus Oregon. We also have, clinical facilitators and facilitators. And so I think it would be great I'd be happy to sit down with you if it's helpful and kind of talk through what some of those differences might be. And if there's a way to sort of kick it to a Colorado version. I
Yeah.
think.
Yeah, that's a good question too. We currently ask for the facilitator characteristics. When a facilitator enrolls as a research participant, we do ask about their professional licensure. So
Mhm.
regardless of which tier they fall into at the state level, we'll always know what kind of professional licensure they have.
Okay, that's great. Um, all right. I guess I'll hop over to one of the open questions. So beyond PHQ-9, are there plans to use other validated mental health tools, example, GAD-7, PTSD checklists, or quality of life scales to capture broader treatment effects?
Yes. In fact, that big giant table that Jazz showed, almost every single one of those is a previously validated measure. And we went through an onerous process of looking at every single item on every potential measure to land on the measures that we landed on. So yes, we do use the PHQ-9. The HADS is what we use for anxiety. PTSD is the PCL-6. Some of the like substance use ones are already named there, like the Audit C for alcohol. So every single one of these things, with the exception of there are a handful of like satisfaction measures that we have pulled from our Delphi study, but pretty much every single domain that you see here is a previously validated measure that's been used in the scientific literature for a long time.
Awesome. Thank you for that.
Yep.
And then I saw a question here. I'm having trouble finding it, but I think it's an important one to ask. There was a question about, I don't know why I'm not able to see it here, about sort of will clients have to potentially repeat these? Or I think maybe the question is getting at like, is there a way for the Healing Center to access the data about their clients to inform their own decision making?
Yes, that is indeed the plan. So the tricky thing is that we need a critical mass of data to share back with the healing and service centers in order to keep it confidential. Right. So if you only have data on one client and you get a report about one client, we've essentially broken that client's confidentiality because you know who they are. So, there's small cell suppression guidelines that we follow, but that's the really big difference between our program and, for example, what the state level data collection does in Oregon is that there is no feedback mechanism for quality improvement, whereas for us, that's one of our primary drivers for doing this work is to be able to offer that feedback. Right now, it's a manual process, but it is on our roadmap for our software development to have those kinds of analytics available, sort of at the push of a button. So, once we have enough engineering time and we get that those features enabled, that'll be a really, really important function. Again, dependent upon a critical mass of data where we can maintain the confidentiality of the responses.
Yeah,
Appreciate.
and Adi, I'm seeing another question here from Allison that's asking if we can see the list, if they can see the list of validated tools, and do they have the ability to see the results over time at each time point? And so I imagine that's that like click of a button once we get that functionality in the platform.
Yep, exactly. So, Allison, these are excellent questions, and it's stuff that we're working on literally right now is how do we best visualize all of these responses on these validated measures. So it is under development right now with our innovation team at Oak Tree. And I do want to take just a moment to shout out our innovation team at OHSU. Essentially, what this is an enterprise level software agency that lives inside the university. These are exceptionally talented software engineers who have spent their entire job is building research grade software. And their level of expertise and being able to handle extremely sensitive research data and understanding this unique environment of interfacing with the researchers themselves, like Jazz and I, we have a really exceptional environment to be able to have really powerful tools to be able to answer questions exactly like this. So it is definitely on our roadmap, under development right now as we speak, and we hope to have something available soon. The very first place that will appear is on our website. So the first version of this analytics will be a really big picture one, that's aggregate data for all of the clients across all of the centers. And then once we have that foundation built, we can, sort of filter those results based on different service and healing centers.
Awesome. I think this question is kind of connected. It's also from Allison. It's a question, can you send us a dummy survey so that we can kind of inform clients what to expect?
Mm-hmm.
Um,
Yeah, so this is tricky. So I answered in two parts because we have the easy way, which is here are all the domains that it would look like. If you, Allison, are really interested in getting in there and digging in yourself, we can give you access to our sandbox, and that will enable you to go in as a facilitator and as a client to fully see the experience. So that is possible, but the more streamlined answer to that is to send you the one pager that has like, here's what to expect in terms of the types of questions that you'll be asked.
and is that one pager broadly publicly available, 80?
It is not at this time, but it is. Yeah, I have an email out to a member of our team to check on the status and see where it lives and how our IRB allows us to distribute it. So there, we do have to be compliant. This is a heavily regulated research environment. So yeah, I have your email address and I will follow up.
Yeah, got it. And from what I'm understanding in general, it sounds like the best way to get involved in this study and kind of learn some of these details is to reach out to the open study at ohsu.edu if you're a facilitator or healing center on this call.
Yeah.
Awesome.
Yeah, and I also been sharing my own personal email if anybody wants to get in touch with me. It's Jazz Kadash, exactly how it's spelt at gmail.com. And exactly how it's spelled in that little box at the bottom. And if you have any questions about how to get involved, if you have a healing center, for example, you're welcome to get in touch with me to chat more about how you can get your facilitators involved in the study. It is really just emailing, the open study at ohsu.edu, but I'm happy to chat with you as well if you have any more questions.
I saw a question from Owen. This is an easy one to knock out, so I can just answer it. So Owen's asking, he's seeing, or they're seeing a lot more sessions logged in Oregon and Colorado. That is simply due to the amount of time we've been operating in Oregon compared to Colorado. So we, only recently in the last month or 6 weeks maybe began outreach in Colorado, whereas in Oregon, we've been collecting data since November. We absolutely do anticipate that the volume of both facilitators and clients in Colorado will accelerate tremendously as more licensees come online. Oh, Tasha, you're muted.
Thank you for that. So we have a question from Adrian. Since antidepressant use is being tracked, but other concurrent medications aren't, are there plans to expand medication data collection in order to better understand potential drug-drug interactions or confounds in treatment outcomes? For example, SSRIs, benzodiazepines, or pain medications in populations with comorbidities?
Yeah, this is a really great question, Adrian. Our main challenge is the balance between comprehension and concision. It has been exceptionally challenging to attempt to focus on the most important questions. We are extremely sensitive to the respondent burden. So, right now we feel pretty good about our ability to retain people in the study, which means that our survey isn't too long. But the more questions we add, the more at risk we are of losing people in terms of their engagement and their completion rate for the surveys. So, again, there is some skip logic involved. Are you currently taking any medications? Yes or no, right? Like there is some ability for us to streamline that. But it's a really, really tricky balance, and we have to heavily lean on the literature to tell us what are the most important questions to focus on. So right now, things like SSRIs, benzodiazepines, opioids, none of that stuff is on there. One of the reasons that antidepressants are on there is because we heard from service centers in Oregon that people were changing the administration dose of psilocybin based on whether or not the client was on an antidepressant. So we had a really, really strong smoking gun telling us we need to be measuring antidepressants. So if we end up having those kinds of, other really important red flags, again, the custom software platform allows us to make those changes, but we have to have a very, very strong rationale to do so to limit participant burden.
Appreciate that.
There's a question here that's interesting. An anonymous attendee says, in Colorado, what percentage of respondents are unregulated or unlicensed versus regulated and licensed contributors? And primarily asking because psilocybin use has been legal statewide since 22. So again, as AD mentioned, we've only been doing outreach in Colorado for the past 6 weeks or so. And so we only have maybe a handful of facilitators who are contributing information to our platform. And so we just simply don't have uh, really that much to determine. It's like maybe 3 or 4 facilitators right now. And so we hope that as more people kind of join the platform, there is an opportunity, as I mentioned, to indicate whether you are licensed or not, and that would help us be able to better answer your question. But currently, we don't have that information.
Yeah, and I guess one other thing that comes to mind for me to mention, because I know there was a question earlier about looking at like micro healing centers versus standard healing centers. Another piece that we have in Colorado that's different from Oregon is we do also have the at-home administration, which is within the licensed program, but it's at somebody's home. And I do think it'd be really interesting to be able to include that, especially because that's key information for the state to assess the safety of that particular use case and be able to make decisions around, are there other cases that could be safely held within that container as well? So I think one kind of clear example of how this type of information can really inform policy decisions moving forward as well.
Yeah, and again, the platform is a web-based platform, so clients can fill out the surveys in their home as well as facilitators. They don't have to be with the facilitator in order to fill out the baseline or even follow-up surveys. And so, exactly what you're speaking to, Tasha, this way of gathering information is really accessible to people who are working at home.
Great. Um, and so we have
So many questions. Thank you all so
Yeah,
much. Yeah.
it's a lot of engagement. I can take on this individual level data question from Allison. Um, so yes, you're right that, the way that our reports are intended to be structured are aggregate. We are not able to share individual level data, client data or patient data, with anyone outside of the research team. So if you're interested in a particular client's scores on PHQ-9, for example, you're right. We won't be able to provide those for you. That level of resolution, if you're interested in tracking that over time for a particular client, that would be something you'd need to do yourself. And then who is responsible for following up on adverse events? This is a really important question. So right now, our research protocol, we have two kind of safety nets in place. One of which, if a person answers any question that they experience some sort of harm, we have some HTML pop-ups that provide them resources, for example, to Fireside, ICERS, and I'm forgetting the other one, but those sort of pop-ups are built into the platform if a person responds that they've had any sort of unwanted event. Um, the other thing that we do is when a client enrolls, they have the option to opt into additional research. If they choose to opt into additional research, then we send them a referral to a team at Emory University who we're collaborating with on the impacts of negative and adverse and challenging psychedelic experiences. And so they will be, sort of warmly handed off to the Emory team to track what happens to them over time. Now, in terms of providing them additional resources, you know, it would be nice if we knew what to do, but at this point, like this is a research study, and so we're open to your feedback in terms of what should happen there and what we could be doing better. But as a research team, it's not our we don't have the qualifications really to provide any, services. All we can really do is, um, make available resources known and hand off to other teams that are doing other kinds of research on adverse events.
All right, so we are actually at time for this webinar. I just want to thank you both again, Adi and Jazz, as well as everyone who has joined us live for this, and thank you for all your wonderful questions. Just really encourage you, if you're somebody who's eligible to participate in this study, I think it's one of the key things that we can all be doing right now to support the sustainability and also kind of the quality and impact of this movement around psychedelic therapies. So please be in touch, and yeah, look forward to seeing you again soon. Thank you guys.
Thank you so much, Tasha.
Thanks
Thanks,
for
everyone.
having us. Yeah, thank you for all the amazing questions. Yeah. Have a great day.